So Sanjay asked me to talk about DILI. I know know Guru, I thought, has given an excellent talk not too long ago, within the last 2 months. So I thought I would focus in an area that I've done some work, that is DILI in patients with chronic liver disease. As gastroenterologists, I assume many, if not all, you are gastroenterologists, and I think either we are treating patients with underlying liver disease or we get consults for this question. So I put this slide set together, and I hope you find it instructive. These are my disclosures. Take a minute to see. Have consulting agreements, research support, and no speaking engagements. This is the outline. I'll touch on some background. This could be repetition from Guru's talk, but maybe some of you have not listened to his talk. And then most, 2/3 of my talk will be focused on DILI in people with underlying liver disease. In terms of DILI, it's a big deal. 3 to 10% of acute liver injury in the US is from idiosyncratic drug-induced liver injury. But if you add acetaminophen, that is your paracetamol, accounts for up to 50 to 60%. And the common cause for medications to be abandoned during drug development. Compounds are going through phase 1, phase 2, and then all of a sudden DILI comes up and program had to be abandoned. I live in Indianapolis. Eli Lilly is next door to us. About 5-6 years ago, they had 2 compounds that had to be abandoned for diabetes that costed them close to $1 billion. And more recently, they had a drug for ulcerative colitis, same story, about $250 million. Our work has already been done, just to give you a flavor that this is a big deal, at least for drug development. And a common cause for drug withdrawal or restrictions for using often approved medications. We all know the triglyceride story, bromfenac, if we're trained in 90s, number of them. Zimalagatran is, AstraZeneca drug, tolvaptan. It's on the market for hyponatremia, but I think it has a DILI signal. More recently, obeticholic acid is approved, but it does have DILI signature, especially if you use in people with advanced liver disease. There are 2 types of DILI. Just to touch on background, this is direct hepatotoxicity, the prototype being paracetamol. Bottom line is, if you give high enough dose, most people will get DILI. Typically, you have serum enzymes, mostly AST and ALT are high, but you can have acute hepatic necrosis, sinusoidal obstruction syndrome, and so forth. Nodular regenerative hyperplasia, especially in post-kidney transplant patients, is thought to be direct hepatotoxicity due to sinusoidal injury and from azathioprine. The talk will be focused on idiosyncratic hepatotoxicity. Basically, this is unexpected. This is rare. Most people that take it are fine, but some patients idiosyncratically, unexpectedly get the hepatotoxicity. There are some in the audience who are an expert, and I'd like to draw your attention to Dr. Deborah Bobby, who has done really fantastic work, internationally recognized. And isoniazid is a big thing in India and Far East and Africa as well. Triglyceride, we talked. In the Western world, the single most common cause for DILI is amoxicillin clavulanic acid. It gives a cholestatic picture, minocycline, diclofenac, so on and so forth. But generally speaking, there is not a good animal model, and there are plans now underway for organoids, so organ on chip type thing. And it remains a challenge for clinical and basic science. So interesting thing about DILI, idiosyncratic DILI, is it can present as any type of liver disease. It can be hepatitis. It can just be asymptomatic elevations in liver enzymes, which we probably see a fair bit from, actually even from isoniazid. To 15% just have these asymptomatic increases. Can be acute hepatic necrosis, bland cholestasis. It can cause chronic hepatitis cirrhosis, interestingly, NASH, You have this lactic acidosis, steatosis, hepatic dysfunction used to be these sort of mitochondrial toxins from antiretroviral agents. And there was this classic hepatitis B drug called FIAU, phyoluridine, killed patients as well as required liver transplantation. Finally, nodular regeneration, sinusoidal obstruction. So the bottom line, though, is you have to keep DILI in a differential anytime you see a patient, any new patient with liver disease. It can really mimic everything. Important to draw your attention to when you see DILI, it would be worthwhile to separate this into cholestatic versus hepatocellular. This is basically whether you have high aminotransferases or whether you have increased alkaline phosphatase. There is an R ratio, but you really don't have to do the math. But it helps you in two ways. One is it is a guide to prognosis. Generally speaking, hepatocellular is bad than cholestatic. Second is that some drugs have signature. For example, augmentin almost always causes cholestatic, whereas isoniazid causes hepatocellular. This sort of helps you to diagnose, especially when patients start multiple medications at the same time and you're trying to tease out what's causing what. And I think this pattern recognition can be helpful. Just a slide on a few things that are used in drug development. Some of you may be familiar with it. There is a thing called Hy's Law, and this is identified by late Hy Zimmerman. It's considered to be father of hepatotoxicity field. He's written 2 wonderful textbooks, and even to date, they are just fantastic monographs. Hy's Law is, he identified this phenomena. If you have elevated aminotransferases, at least 3 times or higher, but if there is also jaundice, but without increase in cholestasis or increase in alkaline phosphatase, and of course there is not a competing etiology, you have a 10% mortality. And this is really important for our practitioners. A lot of us really freak out when we see AST, ALT at 1,000, but if bilirubin is normal, they're going to do fine. It is the bilirubin in context of hepatocellular that just means that you've lost a critical mass of hepatocytes due to necrosis that is starting to give bilirubin increase. That's when you should be worried about. In other words, hepatocellular jaundice is what you should worry. To some degree, this also matters for viral hepatitis, but not as pronounced as it is for drug-induced liver injury. The other one is Bob Temple corollary. Dr. Temple is a renowned scientist at the FDA. What he found is that just about all compounds that have been identified to have DILI in the clinical practice, when you go back and look in clinical trial databases, there is an imbalance in ALT 3 times upper limit of normal between active comparator and the placebo. And finally, there's John's senior role, which means in a drug development clinical trial, if you have an ALT 10 times upper limit of normal, for every 10 cases, you're going to have 1 Hy's Law case. If you're going to remember one thing from this slide, remember hepatocellular bad jaundice is bad news. Okay. And this is called an e-dish. Once again, you see this in clinical trials. If you happen to be in drug safety monitoring boards, or this may come up in your board examinations. What you do is when you're doing a clinical trial, you plot peak ALT times upper limit of normal on x-axis and peak bilirubin times upper limit of normal on y-axis. This is the same thing, a pictorial depiction of Hy's Law. So you have 4 quadrants. Upper right quadrant is Hy's Law. In other words, you have high ALT and also you have a high bilirubin. If you have an imbalance in this particular group, what you're seeing here is brown triangles, almost 15 of them to just 1 green circle. So in this case, you can say there's a significant imbalance in Hy's Law between cases and controls. Therefore, this is thought to be a hepatotoxic drug. And the studies are ongoing to modify EDISH. This is called EDISH, evaluation of drug-induced serious hepatotoxicity, applying this to people with elevated baseline liver tests. Also, we are working to plot peak total bilirubin and y-axis with peak alkaline phosphatase for cholestasis, for cholestatic injury, especially in people with underlying liver disease. More to come on this. I'm going to touch on a few other concepts. As I said, idiosyncratic drug-induced liver injury is thought to be dose independent. However, this is the first paper or one of our faculty, Dr. Craig Lambert, when he was actually a medical student, started to work on. This came from the observation that most patients with drug-induced liver injury who either die, need liver transplantation, or the compounds that have been taken off the market, they're not given at high doses. Excuse me, they are given at high doses. You don't see compounds given at 10 milligrams or lower that causes significant DILI. So Craig did this thesis to look at the dose of compounds that are available at the time. This is now almost 15 years ago, and the risk to cause ALT increases, jaundice, liver failure, etc. And what he described is that if there is a significant dose relationship for a liver failure, death, or liver transplantation with very significant p-values. Craig Lambert went on to do a subsequent study, still he was a medical student, mind you, looked if the compounds that are hepatically metabolized are turning out to be more hepatotoxic. I'll come back to why this is important. So, and what he was able to demonstrate is if you have extensive hepatic metabolism, there is a significantly higher likelihood a compound would be more hepatotoxic. Okay. Then in 2009 hepatology paper, he combined dose plus extensive hepatic metabolism. And what he has shown is if you're giving a compound at 50 milligrams or higher daily dose by mouth, and if it happens to be extensively hepatic metabolized, you have a significantly higher risk than other combinations. This led to FDA putting together this rule of 2 and rule of 3. Rule of 2 is daily dose given at 100 milligrams, and lipophilicity basically means that if a compound is lipophilic, it has to be metabolized by cytochrome P450. And if it is lipophilic, then it can be directly conjugated, either sulfation or glucouronidation. So, and then subsequently FDA, so they're largely based on Craig Lambert's work, daily dose, lipophilicity, as well as reactive metabolites. Basically, what it means, though, is if you have a compound that is hepatically metabolized and generates reactive metabolites, they can just be toxic to hepatocytes. And if you have more reactive metabolites, more likely you're going to have hepatotoxicity. Not everybody buys into this concept, but if you're advising a pharmaceutical company, or if you're on a data safety monitoring board, this can just help you to see whether a compound is going to be hepatotoxic. Just moving into why patients with underlying liver disease may be at a higher risk for DILI. In patients, especially with cirrhosis, there are a number of reasons why the pharmacokinetics of a drug may be altered. First is the intrinsic capacity. That just means that there are decreased enzyme synthesis within the liver and decreased activity. This shouldn't surprise you. 80% of drug metabolism is in the liver, and the liver metabolism is done through the cytochrome P450, which basically are proteins. As the liver disease gets worse, there is less, prothrombin, less albumin. The same way you're going to have a lower cytochrome P450. So that can explain a reduction of blood flow. As you know, as the liver disease gets worse, there is a lower portal flow. There may be a buffer response, increase in hepatic arterial response. Nonetheless, because of shunting, etc., hepatocytes have a net new blood flow. changes in protein binding, reduced delivery of oxygen. There is just a tremendous literature, especially or 60s and 70s, showing that oxygen is really important for cytochrome P450 activity. Altered transporters, which are really important for drug metabolism, turning out to be important for certain types of drug-induced liver injury. All these things can affect drug metabolism, thus can influence the likelihood of causing DILI. This is a cartoon from Dr. Sherrington from Tucson, really an expert in drug metabolism in NASH, showing, especially in NASH, whether it is because of obesity, whether it's because of underlying liver disease, insulin resistance, there are profound alterations in cytochrome P450 as well as many transporters. We have recently published this paper, I think, in Nature Communication. Nick Powell is a young faculty member here at IU, showing clinically important alterations in pharmacogene expression in fibrotic non-alcoholic fatty liver disease. And upper cartoon, what you show is almost, I think, about 24 different cytochrome P450 transporters modified, both upregulated as well as downregulated. The volcano flat plot on the bottom shows the same thing. Far left here is cytochrome P452C19. That's the one we highlighted in the paper, but there are a number of other ones as well. For example, this particular one right here is significantly altered, but it is not, x-axis is severity of liver disease. So bottom line from these two slides is liver disease has profound alterations, especially in NAFLD and NASH, advanced fibrosis. You're going to see alterations in drug metabolism for the reasons I've shown in that table. So let's go now to underlying chronic liver disease and DILI. So in this matter, what are the important aspects? Are individuals with chronic liver disease at more risk for idiosyncratic DILI? Traditionally, if you look in the textbooks, as I was studying, the dogma has been that patients with liver disease are not at a higher risk for idiosyncratic DILI. It is just, if they get DILI, they have lower reserve, they're going to have worse outcomes. That's the second one. We will touch on. The third is causality assessment. We won't touch on, but when you're assessing whether a liver injury in a patient with chronic liver disease is due to DILI or something else, it can be messy. It can be confusing to use traditional instruments such as RuleCam. Sorry. So if you look at the literature, these are the compounds that appear in the literature to have an increased risk of hepatotoxicity in patients with liver disease with some evidence. We all have read isoniazid, should be avoided in people over the age of 35 or 40, in people with advanced liver disease. Old literature. There is old literature that highly active antiretroviral therapy, nevirapine especially, can be more risky in people with chronic liver disease. Methimazole, methotrexate, although this has been questioned now. Tamoxifen is pretty notorious. There's much literature saying that if you give tamoxifen to people with NASH, it can progress rapidly to cirrhosis. That needs to be tested, but these are the compounds that appear in the textbooks, old literature. I must say, though, the evidence is not as rigorous as one would like, but nonetheless, this is how these are described. In terms of underlying liver disease and risk of chronic DILI, not acute DILI where there are increased enzymes, but you don't realize that they're developing chronic liver disease, but it can happen. Tamoxifen I already touched on. It can certainly cause steatohepatitis. Underlying risk factors include obesity, underlying steatosis, amiodarone. Obesity is a risk factor. Methotrexate is being questioned now. There is a recent article by Raoul Andrade and Einar Bjornsson questioning whether methotrexate truly causes worsening fibrosis, or is it just the epiphenomena because of underlying liver disease. Irinotecan is used for colorectal cancer chemotherapy. It can cause steatohepatitis, and obesity is a risk factor. Stavudine is a Hep B HIV drug, the same thing. There are two compounds that were abandoned by Eli Lilly, a company that is sort of next door to us, a novel glucagon receptor antagonist and a basal insulin lispro, pegylated insulin. Both had a lot of promise as drugs for diabetes, but they both cause significant hepatic steatosis on drug, more so than the placebo. The development protocol had to be abandoned. And interestingly, PNPLA3, which is a risk allele for NAFLD, turned out to be a risk factor. Very interesting, that drug-induced hepatic steatosis. And so now these data are nearly 20 years ago. When I was a young faculty in early 2000s, statins were just getting popular. We were getting a lot of consults from primary care physicians. Hey, I have a patient who has dyslipidemia, but they also have increased ALT. Can I give statins or not? At the time, the FDA package insert said, if you have liver disease, don't give statins. So I did this study. Let me just walk you through. So there were three groups of people here. So the middle group is patients with abnormal ALT who got put on statins. On the left is patients put on statins, but they are normal ALT. On the far right is just the liver disease controls. They were not put on statins, okay? So then we looked at increase of ALT anywhere from 1 to 10 times upper limit of normal, more than 10 times upper limit of normal. What we saw is the middle category see increase in AST and ALT, 1 to 10-fold upper limit of normal, significantly higher on patients receiving statins who had abnormal ALT compared to normal ALT. But though when you compare them to people liver disease controls, people had liver disease, but they were not put on a statin, they were the same. And then also when you look at 10 times upper limit of normal, there were no differences. I thought this was an important contribution that led to at least 10 follow-up studies that confirm this observation, that patients with liver disease have increased in ALT fluctuations, whether you get put on a statin or not. And this also subsequently led to package insert modification. Now, I think statins are given to patients with underlying liver disease with more confidence, at least in the US family practitioners and PCPs. Then this is a subsequent study. Craig Lammert, who I said was my medical student in 2003, now he's a faculty member back at IU. He had a tour at Emory and then at Mayo, had come back to us. So we have done a study. This was published about 4 years ago in Clinical Gastro and Hepatology to test whether patients with underlying liver disease have an increased risk of all-cause DILI. Remember, the gastro paper I just reviewed was specific to statins. So our hypothesis was patients with chronic liver disease are not at increased risk for DILI due to common hepatotoxic agents. What we have done is we have health information exchange. Basically means that 90% of hospitals in the state of Indiana, by the way, all our electronic records our medical records are electronic. Everything we see, outpatient, inpatient, prescriptions, everything is in the computer. So there is a health information exchange. 90% of the hospitals exchange the data. So a patient goes from Apollo Hyderabad to Apollo Secunderabad. It is shared. So this is beautiful data set. So what we were able to do is construct two groups of patients. One is chronic liver disease cohort, that patients at elevated ALT 45 or higher, at least 2 occasions for 6 to 24 months, at least 6 to 24 months apart. and in the absence of Hep C, Hep B, heavy drinking, hypotension. So this was supposed to be quasi non-alcoholic fatty liver disease. And then we had a control group. Actually, we had two control groups. One is just ALT less than 45. The other one is gender-specific ALT and criteria. And then what we have done is we looked at cases and controls, and we have connected to pharmacy prescriptions. And if they received top 10 DILI drugs, and after receiving drugs, if they had suspected DILI within 12 weeks after receiving this drug. Let me just explain the sequence once again. So we had patients with chronic liver disease, we had controls, and we have identified of those 200,000 patients, we have identified those who received one or more of top 10 drugs that could cause DILI in the US, okay? And then once you received, we looked at the frequency of suspected DILI for 12 weeks, okay? And our hypothesis is the CLD is at no high risk for DILI than the control group. And then I was surprised. I'd like you to look at really the bottom rows here. So the middle column is the chronic liver disease cohort received one of 10 drugs at about 6,000 patients. And the control group 1 is 62,000. And they were no liver disease, but they received hepatotoxic drugs. Control group 2 is the same story. What you saw is if you have chronic liver disease and received one of 10 drugs, your risk of DILI, suspected DILI, is 2.1% compared to 0.4 and 0.3. This is significantly, this was significant by statistical testing. This came to about an odds ratio, about 6 or 7. And we had some positive other things. The frequency of death and liver transplant in the middle group is significantly higher than the control groups, sort of confirming this could be a real phenomena. What I was surprised, though, our analysis proved our hypothesis was null, okay? Then I was surprised to see subsequently a South Korean population-based study appeared showing the same thing. The risk of DILI is doubled after NAFLD diagnosis. This is a quirky design. And there was about 15 years ago, there was an Italian prospective study published in Hepatology research showing the same thing. If you have NAFLD, it is significantly associated with DILI in patients with an odds ratio of 4. What do these data mean? That if you have suspected NAFLD, statins are safe. Our paper from 2004 in Gastro plus dozen other papers confirm that. But NAFLD as large may be at risk for DILI from all compounds, just not from statins, okay? Once again, these are epidemiological studies. Use your judgment in your clinical practice. But this needs to be confirmed, but something interesting for you to be aware of. The next, though, is the story of saroglitazar. This is truly, I've been involved with the saroglitazar development for at least 7-8 years or so. This is really a prized development by one of the Indian companies. Indian pharmaceutical companies do really do a fantastic job with genetic drugs, but the new chemical entities are really rare. In other words, compounds discovered, developed in India are far and few in between. I may not be overstating that the saroglitazar was one of the first new chemical entities. So, it's approved in India for NAFLD and also for dyslipidemia. This is a combined PPAR alpha gamma agonist. And the story here is, this is the only instance that I know, maybe rifampin, I'll touch on it in a moment, where a compound is hepatotoxic in certain type of liver disease, but not others, okay? And correct me if I'm wrong, Ravi or Prasul, Harshad, I'm not aware of any compound that is selectively hepatotoxic to one type of liver disease, but not others. But saroglitazar seems to be the case. It's been used in more than 1 million lives for NAFLD and diabetic dyslipidemia. I've not seen any reported hepatotoxicity either from the company or in the published literature in that population. However, when we did a phase 2 BBC clinical trial, Raj Vipalanchi is the first author in this Journal of Hepatology paper that was published last year. 3 out of 13 patients on 4 milligrams of DILI, of saroglitazar had DILI. 1 was highly likely, 2 improbable, and 1 out of 14 patients, the 2 milligram dose had probable, typo here, probable DILI, probable causality. There were fortunately no jaundice, rapidly reversed with discontinuation. And by the way, if you're doing drug development and if you have 3 DILI episodes out of 13 patients, this is simply not viable at that dose, okay? And in the paper, Raj had these vignettes showing how these AST and ALT peaked. And what you see is in all these patients, at least 3 out of panel B, panel C, and maybe panel D, the blue line is alkaline phosphatase rapidly reduces, showing that it actually is a effective drug for alkaline phosphatase, but it has this 4 milligram, has this DILI signature. I'm going to stop here and just for a moment ask Harshad or Ravi, Sanjaya, if you want to weigh in on this particular thing that a compound is selectively hepatotoxic. There was some literature early on that rifampin could be hepatotoxic to PBC, but we know rifampin can be hepatotoxic for other indications as well. Harshad, do you want to make any comments about this?
There is increasing use of saroglitazar and NASH as well as the dyslipidemia in India. But I have not seen a single case where saroglitazar has given rise to DILI, or at least raised enzymes.
Very interesting, though. My hypothesis is now, this is a PPAR alpha agonist. And in a cholestatic liver disease, these PPARs are significantly impaired. What you do is PPAR alpha does is increases this FXR. It almost behaves like obeticholic acid, the saroglitazar. As we know, obeticholic acid is hepatotoxic in advanced PBC, et cetera. That's sort of how I'm reconciling, but this is a very interesting phenomena. Just curious to Sanjaya or Ravi, do you have any experience with hepatotoxicity selectively in one liver disease as opposed to others?
I have no experience with this drug, though, unfortunately. But we have been a part of this, we're part of this study. So once we have it, maybe I'll get some more ideas.
Yeah, I'm part of this this study paper, but yeah, I'm not aware of any other drug which is selectively hepatotoxic in conditions. This is the first one
very interesting.
Yeah.
Yeah, thank you. And by the way, Ravi and Sanjay, thank you for being part of some of these clinical trials. So then the next data set are, I think this is not rocket science, that if you have liver injury in people with underlying liver disease, it is bad news. Harshad, I'm happy to share the slides with you. So the first, the top is, the panel is the paper that we published in 2015 from drug-induced liver injury. Out of 899 patients that we reported, 10% had pre-existing liver disease and 810 did not. What we saw is about a 4-fold higher risk of death. So this is the first instance, what people believe to be true, we were just showing it to be true. Subsequently, Spanish registry, this is Dr. Andrade and Dr. Lucena, really pioneers in the field, have shown the same thing. If you have underlying liver disease, the risk of death could be significantly higher. And this is an interesting, the same thing, if you have liver disease, does it modify the outcomes? What I'm showing on the left side is this very interesting relationship between comorbidity index and 6-month mortality in suspected DILI. This came from a a patient whom I was seeing with jaundice and DILI, and at the time, everything we had in terms of prognosis for that patient is liver-related mortality. You know, patients don't care whether they die from liver disease or overall mortality. So Marwan Gabriel, who is a colleague of mine, really fantastic investigator at IU, we postulated that underlying comorbidity really defines the outcomes of DILI. And we all have seen, you know, especially when you give isoniazid for latent TB, which is common in this part of the world, just isoniazid by itself, they're otherwise healthy. They get profound jaundice. They do exceptionally well. In contrast, you have an elderly patient with COPD, cancer, etc. They give augmentin or amoxicillin clavulanic acid, have somewhat mild jaundice, and they cannot survive that episode. This led us to hypothesize that Chalasani comorbidity index, which is sort of how you measure comorbidity, defines outcomes. On the far left is showing in the red curve is if you have significant comorbidity, you can just replace significant comorbidity with advanced liver disease. The curves are exact the same. In other words, the blue is people without liver disease, the red is people with, if you have underlying liver disease. This is how dramatically the curves separate. Of course, this depends on the nature of liver disease. If you have advanced liver disease, cirrhosis, and liver failure, of course, it's going to be pretty bad. On the right side is a nomogram that we've developed. I hope it is projecting well based on albumin, MELD score, and Chalasani comorbidity index. You can get number of points, and that gives you really precisely. We had a discovery cohort from IU, and we prospectively validated on a cohort from Skip Hayashi at the University of North Carolina. The AUROC is mind-boggling, 0.97, both discovery and validation. Strongly encourage you to use this, and I think there's a web calculator as well, gihep.com, you can play around. But once again, draw your attention to the nomogram. The other thing is just underlying liver disease clearly separates the prognosis. So the next is more recent. I think, Harshad, I think I reached out to you about this particular question that we are investigating. As I said, generally speaking, cholestatic DILI has better prognosis compared to hepatocellular DILI. It's been our experience in patients with underlying liver disease, whether you have cholestatic or hepatocellular, overall mortality is equally bad, whether you die from underlying liver disease or underlying comorbidity. So these are data sets, these are not published yet, and we are combining our data sets with Spanish registry, Latin registry, etc., showing that if you have underlying liver disease, death is significantly no different, whether you have cholestatic DILI or hepatocellular DILI. The same thing for liver-related deaths, liver transplant or chronic DILI. And very interesting. And then the other thing I would draw your attention to is the mixed DILI generally tends to have excellent prognosis. You know, this was, Harshad, when we first, I think 2008 Gastro paper is the first time when we picked up this mixed DILI has great prognosis. And that continues to be the case. And I think other registries have shown the same thing. And I don't quite understand why mixed DILI would have this 0 transplants and 0 chronic DILI. Mind you, these are small numbers, but this is generally how the data look. When you're considering DILI in patients with underlying liver disease, the differential, I don't have to tell your audience, you know, your master clinicians, your bedside skills are exceptional, but you have to think about heavy alcohol consumption, other comorbidity, concomitant medications, idiopathic AIH, natural history of underlying liver disease. You have to keep that in mind. Some patients, especially I'm going to draw your attention to this one. These are data from Gilead cirrhosis trial, This is in the placebo arm of Gilead trial showing ALT 5 times upper limit of normal is seen up to anywhere up to 5% of patients, okay? And the same thing with alkaline phosphatase, 2 times upper limit of normal can happen in 2 times, in up to 2 to 3%. Total bilirubin can fluctuate as well. So this is in the placebo group, drawing the attention to you that just the underlying liver disease can cause fluctuations or increase in bilirubin, or other things, either they drink or they take paracetamol. These things can happen in a placebo group that can also happen in patients with liver disease that you're caring for in your practice. Just the last few slides, I really appreciate your patience. It's when you have patients with underlying liver disease that you're managing in your practice, avoiding suspected DILI drugs is really important. Like we don't give isoniazid. Please, we try to avoid isoniazid in patients with cirrhosis. The same thing should apply to all other things: amoxicillin, clavulanic acid, nitrofurantoin, Bactrim. At least these in the US are the common culprits. You have to see the Indian network of DILI, Harshad, that you led. You should have top hits. And then I think you should encourage your clinicians to look for alternatives. For example, quinolones. Some quinolones are more hepatotoxic than others. For example, ciprofloxacin tends not to be as hepatotoxic. For example, moxifloxacin. I think you can play that to data from India. And that sort of concludes my talk. And just to take home messages, statins are safe in patients with the non-alcoholic fatty liver disease, but there is a suggestion epidemiologically from our work as well as from Korea and Italy, NASH may be a predisposition to all-cause DILI. Not so surprising, but the DILI outcomes are worse in patients with underlying chronic liver disease and cirrhosis. Both hepatocellular and cholestatic forms of DILI may lead to liver deterioration, and the data are evolving unpublished. They seem cholestatic no longer enjoys good prognosis in patients with underlying liver disease. Thorough workup for competing etiologies is a must when you suspect DILI, and avoiding potential hepatotoxic medications or herbal agents is really critical. What sort of big thing in the US is curcumin, the famous Indian spice. It is not bioavailable generally when you take as a spice, but when you attach that with echinacea or black pepper, the bioavailability goes up. All of a sudden, it becomes hepatotoxic. And I think this is good things gone wild. So just, watch out. And I think the burden of herbal and dietary supplements, and there are a number of other things. Recently, I had the privilege of writing an editorial in Hepatology International about this as well. So I think you have to watch out herbal compounds, especially in underlying liver disease patients, because they may unknowingly think they would derive benefit. At least when I was growing up, there was this very popular Live 52. I don't know if it is still popular, billboards, etc. So that concludes my talk.